start. Please start, sir. We are live.
Okay, okay. I hope I'm
Yes,
audible
sir.
right now.
Please continue.
So, a very good evening to all. It's a pleasure to be here with the Professor Julia and Dr. AG Unni Krishnan. And in aspect of therapy selection for control and beyond. So, as we know, the famous Indian faculty, Dr. AG Unni Krishnan, he's the CEO and Chief, also the head of clinical care research education, and also oversees a philanthropic rural diabetes care program. He has co-authored the largest multicentric study of subjects with pancreatitis and pancreatic diabetes worldwide. In for the former editor-in-chief of the Journal of Thyroid Research and Practice, and has been former executive editor of Indian Journal of Endocrinology and Metabolism. He has received several awards and Jacob Memorial Prize was awarded in 1998. Post that, he also received Subhash Mukherjee Oration Award for the Endocrine Society of India. He received Srivastava Award of the RSSDI for his contribution to diabetes. He received a fellowship award of the RSSDI in 2017. He also received Dr. Sam G.P. Moses Oration Award by the Diabetes Association of India in 2018. He received the Diabetes Excellence Award at the Digital Diabetes Summit at Hyderabad 2019. So, a warm welcome to you, sir. So,
Thank you. Greetings.
it's a pleasure to have you, sir.
Same here.
So, also with us, we have our international faculty, Professor Julia Madder. She is a professor of diabetes technology at Medical University of Graz and deputy head of diabetes outpatient clinic. She is also the head of Diabetes Technology Research Institute at the same university. Her research work is in the vast areas of diabetes technology, including insulin pumps, continuous glucose monitoring, automated insulin delivery system, diabetes management in the hospital, and decision support system. She has around 190 peer-reviewed scientific paper publications. She has received several national and international awards. She is the board member of Austrian Diabetes Society. She is also the executive board member of the EASD, and she chairs the EASD Training and Education Committee. Welcome, Professor Julia Madder. Welcome, ma'am.
Thank you so much for your kind words. Looking forward to this exciting meeting with you.
Same here, ma'am. So, with this, I would like to give it over to Dr. Uni. Over to you, sir.
Friends, it's a pleasure to be here. I hope my slides are visible and that I'm audible.
Yes, sir, completely.
Yes. So I'm going to start by just setting the context. And this is going to be a very personal perspective of the Indian scenario of diabetes and its complications, and how, in addition to looking at what the problem is, how we can look at, or at least how we try to look at what could be some of the solutions to the diabetes problem in India. So this is my agenda. It's a very short lecture. diabetes management in India, there are challenges, our experience in the community, and how we tried to design a new way forward. So we know that there are regional disparities in the prevalence of diabetes in India, but if you take an average, about 16% of urban Indians have type 2 diabetes. And this is a paper showing you that the HbA1c is about 8.9% in people with diabetes in India. This was a paper, of course, authored by Dr. Mohan, and I was also an author in this paper. So these are some pictures from our rural diabetes project. Many of you know that, excuse me, in addition to our urban tertiary care diabetes center, we also used to run an outreach program, and these are some pictures from the outreach program where our outreach vehicles were equipped with retinal fundus cameras, biotissuometries, and they operated in a hub and spoke manner in and around Pune. And this is just one of the patients we found during our screening program, which covered more than 930 villages. You'll see that this person walked into our mobile diabetes clinic. And if you look at his feet very closely, you will find that some of the toes are missing, and that to hold them together, he has used a mesh or a net. So the reality of diabetes care in rural India, and of course, when you look at the poorest of the poor, is that we need to know more, we need to do more, and we need to do better. The problems are that about half of diabetes in India is undiagnosed. And of course, there are problems of access, awareness, personnel, and cost. So one way to look at it is to screen the entire population for diabetes. And the other way is to look at screening high-risk people first and then screening them for diabetes. So this is the second approach, is what we did. You can say it's a low-hanging fruit. We looked at people via a questionnaire who are at high risk of diabetes and then screened them for diabetes in our rural outreach program, and we published it some time ago. In addition to that, there are problems of diabetes or related to diabetes in women, in addition to insulin resistance in puberty, gestational diabetes in adult, postpartum weight gain, preeclampsia. Menopause takes away further the cardiovascular protection, and of course, the effect of age. We also found that abdominal obesity was a problem in rural Indian women, and the prevalence of high waist circumference was about 30% in women and 35% in men. These are also some pictures from our mobile diabetes program, and this is me. I was pretty young that time, and you can see that whenever we used to have a TV playing diabetes related movies, educational content, and you'll see that always the men take the treatment first, and while the women wait. And this is also true in many parts of the world where women are denied guideline directed care and early access to treatment. And some of you may be aware that in late next year, we are setting up a women's health center as a wing of the Chalaram Hospital. This is another young girl with type 1 diabetes, and this is our lead consultant, Dr. Veda. Now, this young lady did not have access to insulin at all. Her father would have to travel to another town to purchase insulin, and the days when she took insulin, she had type 1 diabetes, she felt much better. And we, of course, took care of this patient with diabetes. But just to highlight that in remote rural India, the problems of access are there. You'll also see that neuropathy and foot complications are by far the commonest complications in hospital-based beta, in addition to, of course, cardiovascular and kidney. So we've looked at there are problems in the management of diabetes in India. Let me talk about our experience in the community. So this was a strategy we took. We took community health workers who would go house to house in smaller villages and bring the high-risk people to the larger villages, which is the hub. And on the day the community health worker brought the high-risk people, our mobile diabetes clinic would also visit there to screen. So we had a registration, an examination, and an investigation room, and we screened a huge number of people, as you can see, and this is the design of our mobile clinic. There is a registration counter, a blood pressure, a retinal examination, foot examination, so on and so forth. And we systematically covered the district in a hub and spoke manner. Our project was also highlighted by the Indian Council for Medical Research white paper on management and care of diabetes in India. So this is our analysis of obesity. This is a study of 29,324 subjects from this very cohort. So from this very cross-sectional study, we found that the prevalence of obesity in rural India was about 26%. We also found that as hypertension, as the BMI increased, so did the occurrence of new onset hypertension and new onset diabetes, and that was statistically significant for trend. So we've looked at the diabetes management in India and the challenges. We also looked at our experience in the community. Now let's look at how we try to design a new way forward. So this was a paper. I was fortunate to be one of the authors of the paper and an investigator in this study conducted in South Asia and both India and Pakistan. And it looked at how in hospitals, in urban hospitals, how our non-physician care coordinators could drive outcomes by facilitating guideline-mandated therapies. And it showed that various parameters improved with such therapy. And I hope that this study, which was published in the Annals of Internal Medicine at that time, I hope that our rural project would also show a similar result. So we piloted this project in a rural community in Maharashtra, in Pune. And in addition to the Chalaram Diabetes Institute, the Public Health Foundation, and various other stakeholders participated. This is one of our consultants, Dr. Anjali, who trained the community health workers. This is the mobile diabetes clinic, and this is the registration counter. We selected 2 clusters of villages surrounding primary health centers. And we, in addition to high-risk screening, we brought from 5,000 screened people, we took 300 subjects. And of course, we tried to assess as many as possible at the end. In one group, we made sure that the patients were visited at home by accredited social health activists called Asha workers in India. They were community health workers. And every month they would go to the patient's house and check the glucometer values. They would give advice on diet, exercise, on diabetes complications, monitoring blood pressure. And in the other arm, we would refer them to the government hospital or to their practitioner and just look at routine care. We found that, as you can see, the green color is for the intervention group at the end of 6 months, and the blue color is for the control group. We found that when you intervene with just house-to-house visits, you are able to bring down the HbA1c from a mean of 8.79 to 8.23, and the control group, the A1C increases. A similar pattern emerged in the LDL lipid profile, LDL cholesterol also. This is the data from the full published paper. This paper was published about 2 years ago. You can see the intervention group, the A1C coming down from 8.79 to 8.23. We also looked at the impact of such a community health worker-led intervention, which, just that intervention of education brought down that community's A1C. We also looked at whether that improved the knowledge and the quality of life. And we were pleased to know that there was a significant increase in knowledge and also a better quality of life, and that was also seen. So we found that the project Diabetes with Dignity, that's what we call this project, was significantly better in the intervention group at controlling A1C compared to the control group. And we suggested at that point that the capacity building of community health workers be done. And I'm pleased to say that our paper was, had received success because the government of Maharashtra actually took on this project, and this was implemented statewide, and this continues to be implemented. And we have shared lots of our training manuals and protocols and educational materials, and they continue to help people in rural Maharashtra. So I'd like to conclude by saying that, yes, there are challenges in diabetes management in India. And whether you are in a rural center or in an urban tertiary hospital like me, we should try to find new ways. And I also discussed how we found some success when we designed a new way forward. These are all our partners who participated in the study. I'd like to acknowledge, in addition to all my colleagues at the Chelaram Diabetes Hospital, you can see them in in our dialysis unit here and our lab and other facilities. And you can also see that the government of Maharashtra, the Public Health Foundation of India, was an evaluation partner, because we decided that our project needed to be evaluated by another third party rather than we evaluating our own project. We also thank the central government, the Ministry of Health and Family Welfare for supporting this project. Well, friends, that's in a nutshell the huge challenge of diabetes and the little things we try to do to help people with diabetes in India have a better life. I'd like to thank the organizers for inviting me. It's a pleasure to be here, and thank you so much for listening to me.
Yeah, thank you so much, sir. It was a deep dive in a short period of time for us. So I think it's our time to listen to Professor Julia also, and what data and what interpretation we can gain from her also. So, Dr. Julia, I think yeah, ma'am, you can start, ma'am.
Perfect. I was not finding the button for unmuting for the moment. So we are going to talk about the use of, and I'm moving my head a bit outside of the picture, the use of dapagliflozin and linagliptin in type 2 diabetes with cardiorenal and metabolic disorder. And Dr. Uni set the stage quite rightly. So I think all of us are aware that untreated diabetes is really relevant factor contributing to an increase of late complications if we do not take care of our people with diabetes well. So we have still a lot of diabetic retinopathy around that we could avoid, diabetic neuropathy, as well as diabetic nephropathy and macrovascular disease. So whenever we have the chance, we should really try to use all our means to lower blood glucose and achieve our targets, because we had seen already from historic studies that at least for microvascular complications, by achieving good control, we can definitely reduce many of them. For cardiovascular complications, we were not so sure in the past, because those historic drugs that we were using, and these were the ages of metformin and sulfonylurea and insulin. So that was pre-DPP-4 inhibitor, pre-SGLT2 inhibitor, where we only could manage a certain amount of cardiovascular complications. Having now all of these new treatments around, where we have less risk of hypoglycemia and can achieve glucose control quite nicely, we should really reconsider our treatment goals and should see if we can achieve in those with good health and good health functioning, reduce the HbA multiple complications. We are more tolerant towards less stringent glycemic control. But of course, it's not only the diabetes, but we also need to take care of all the other risk factors being around. And that's a very recent publication, how healthy lifestyle and cardiovascular death are associated. And here we see that even at age 50, people who can manage to avoid the classical risk factors, namely diabetes, overweight, blood pressure, high lipids, and smoking, they have a lifetime benefit over the ones who do not manage these risk factors well. So we do have a longer survival time both for males and females if we manage to control these relevant comorbidities. And that is not a year or two, but it can be even up to 10 years greater life expectancy. So we were talking about prevention of microvascular complications in historic days, but these are data now that are looking into treatment, early treatment after diabetes diagnosis with intensification and achieving an HbA1c below 7%, and the ones who did not achieve that HbA1c below 7%. And we can see there is some glycemic legacy effect out there where we have more or less at 5 years of diagnosis a higher risk of myocardial infarction, stroke, heart failure, and a composite endpoint of cardiovascular events. So whenever we have early diagnosed people, it's not the right time to wait and see, but really to try to get them into control early to avoid complications in the course of the next 5 years or so. Because at least in our European or in my Austrian perspective, we sometimes are a bit lazy and the person comes with the diagnosis of diabetes and HbA1c is maybe 7.2, 7.3, and we would say, okay, let's check the next time, we don't intensify, we just leave it at that. But that's in fact the wrong approach, because the earlier and the harder you hit, the better control you can achieve, and the more late complications, even cardiovascular disease, we can avoid. So what are the advantages of early glycemic control? And here we can see that 1% higher HbA1c at treatment start is associated with 36% higher mortality risk. So even 1% HbA1c difference can make a difference in the course of the disease, and that again at 5 and 10 years into the course of the diabetes. So we should really see that we manage diabetes well and that at an early point in time. And also, we should not only look at the diabetes itself, but also at the body weight, because if we manage to achieve a diabetes and body weight reduction, there is the chance to have even more benefits in the course of time. And these were data from the UK, namely Scotland and the UK, where people were intervened with conventional therapy, so not even medication, but really trying to bring them into good control without medical intervention. And we also do see that there is an association between higher BMI and higher HbA1c. So people who have higher BMI in most cases also do not achieve their glucose control goals. So we should really aim for both, aiming for good diabetes control and also achieving good weight management, because if we simply start insulin quite early and we generate more weight gain, that might not be the best solution for all our people with type 2 diabetes. Similarly, if we initiate sulfonylurea early in some of the population, that could also cause, due to hypoglycemia, more weight gain. I know you have maybe some different types of diabetes, and Dr. V. Mohan did a great study about diabetes types in India, where SUs might be relevant, but consider for many other people that modern treatment options such as SGLT2 inhibitors and DPP4 inhibitors might be more helpful if we want to go down with body weight over time. And what we also can see in even early diabetes, namely prediabetes, that the risk of cardiovascular disease and chronic kidney disease raises with rise in glucose, and also those with relatively well-controlled diabetes have a certain risk to develop cardiovascular disease and chronic kidney disease in the course of 10 to 12 years. So it's really important not only to control the diabetes, but to really frequently check if diabetes is developing and then hit hard and hit early to avoid those avoidable late complications. So what are the benefits of HbA1c and weight reduction? So we can, per 1% HbA1c reduction, reduce diabetes-related deaths already 21%. So that's really a big, big number. We can avoid microvascular complications at even 37%. Myocardial infarction would go down by 14%, and amputation and lethal course of peripheral arterial vascular disease, 43%. Additionally, if we have the chance to reduce body weight by 5 to 15%, we manage to reduce the HbA1c, reduce the blood pressure, and increase HDL cholesterol. So also the body weight reduction may help us to achieve glucose control and then in the long run help us to avoid these late complications. And importantly, it's not that we should be shy in putting down treatment targets also for body weight. We always put down treatment targets for HbA1c, but when I look into the letters from my junior doctors, in many cases, they say, try to reduce your body weight. But if you don't set a defined goal, people do not know what to do. So say 5% until the next visit, 10% until the next visit, so that people really understand what they should work on. And importantly, the clinical inertia is really highest in that group with HbA1c between 7 and 7.9%, where we, on the other hand side, not only have the clinical inertia, but do have the highest chance of achieving our treatment goal. So it's really important to look at that population, because here we can manage diabetes at an important stage and achieve our treatment goals. But as I told you, what happens in our clinic probably seems to be a global problem, that treatment intensification in this category HbA1c usually does not occur within the next 6 months, as it has not occurred in the past 6 months. And people do not only not meet their HbA1c goals, but they also do not meet their body weight goals. So they are increasingly becoming overweight, and more or less half the people with diabetes do not meet HbA1c criteria below 7%, and 90% of people with diabetes are additionally affected by overweight and obesity. And importantly, if you look at the time of this analysis, this was already when more modern drugs were around. So it's not only about drugs being there, but us considering the drugs to being used at a right point in time in that situation. So we also should always keep our treatment goals in front of our eyes, so that we really know that we do not only want to treat the sugars, but we really want to have a positive outcome for our people living with diabetes. So we should define smart treatment goals so that they are specific, measurable, achievable, realistic, and also time limited. We should implement such management plans, reassess our goals of care on the course, also assess, of course, the people's characteristics so that we understand the individual's priorities, the comorbidities, the clinical characteristics, also maybe other factors such as depression, cognition issues, and of course, social status, namely, is the person able to receive the medication, and then really reassess all of these in a regular manner, at least every 3 to 6 months. So when we then again look into the current guidelines that are still standing more or less on a global level, so that's the algorithm from the EASD and ADA, so where we really say, okay, what is the type of person that we do have? Is that person having a cardiovascular disease? And if so, we should go down the line with either an SGLT2 inhibitor or a GLP-1 receptor agonist with proven cardiovascular benefits. If it's a person with heart failure, specifically, we should use a SGLT2 inhibitor with proven cardiovascular benefits. If it's a person with chronic kidney disease, again, look for SGLT2 inhibitor with primary evidence of reducing chronic kidney disease progression. And also consider modern additional agents to be started, such as finerenone, if the potassium would allow. Otherwise, of course, it depends in people who do not have any cardiovascular risk yet to maintain glycemic and weight management goals. So there we potentially could again select combination therapy with metformin and other medication such as SGLT2 inhibitor or DPP4 inhibitor, depending on how high glucose is above target. If the blood glucose is very high, of course, we need to consider also in that population SGLT2 inhibitors. But of course, there might be some issues of people who still are afraid of injection, even if it's just once a week. And I think, as far as I remember, you in India are lucky enough to have the oral GLP-1 receptor agonist around. We in my country still do not have. So my choice in that case, if persons would not inject, would of course be a DPP4 inhibitor. And I brought together to you some of the data, really just summing up what's the effectiveness of the different classes of glucose-lowering drugs. And I do not want to go through all the details of it, but we can see that there are differences, of course, in the glucose-lowering effect. On the other hand side, we do have drugs that have higher risk of hypoglycemia. And on the other hand side, something new came up now, the MASH or MASLD, where we are looking into future benefits, what is observed. And at the time when I took the data out of the diabetes care manuscript, there were the potential benefits reported for TZDs and for GLP-1 receptor agonists. For the other drugs, it was reported to be unknown at that time. But of course, standards of care are now 2025. We will see 2026 standards of care in the near future, so I guess end of the month, beginning next month. So let's see if we will observe some changes here. So if we again look into the specific drug classes, and I want to start off with the DPP4 inhibitors because they have been around for quite some time, have been reported to be efficient in achieving glucose control, especially in people who fail on metformin and who do not want to escalate to insulin or SU at that time. And what we could see when it comes to the Carmelina study, it showed non-inferiority for a 3-point MACE compared to placebo. And also time to secondary kidney outcome was not different from placebo. Then when we look into the Carolina outcome trial, so that was then comparing linagliptin to an active comparator, namely glimepiride. In the beginning, you could see a sharper decline in glucose in terms of HbA1c in the glimepiride group, but over time, there was not a big difference. And in the end, even the HbA1c at 256 weeks of treatment was higher in the glimepiride group compared to the linagliptin group. But importantly, and we do not only look into HbA1c as we discussed, but we also need to look into hypoglycemia, especially in agents that can cause hypoglycemia. So what did we see here? We saw that there were more events in the group receiving sulfonylureas compared to linagliptin. So linagliptin group had lower incidence rates of hypoglycemia and also lower rates of hospitalization for hypoglycemia. So when considering a drug, of course, safety first. You have a drug that has same cardiovascular outcome compared to placebo and added benefit over medication that causes hypoglycemia. If we then switch gears and look into the SGLT2 inhibitors, so what are they doing? So we observed already back in 2015 that the insulin sensitivity improved in the group treated with dapagliflozin treated compared to placebo at 2 weeks of treatment. We also saw that the insulin secretion was higher, resulting in lower glucose levels of the dapagliflozin group and of higher C-peptide levels also in the dapagliflozin group. What can we achieve by adding SGLT2 inhibitors in diabetes care? So we roughly get 150 grams per day of glucose compared to 50 grams per day of glucose in those without SGLT2 inhibitor. And this kind of glucose loss was also proved in a trial with empagliflozin 25 milligrams per deciliter at 12 weeks trials in a population with not that well controlled diabetes. So in these patients over time, you saw a reduction in the fasting glucose, you saw a stabilization of the eGFR after an initial small decline. The secreted glucose remained stable over the 90 weeks treatment period, and the filtered glucose also was around 120 milligrams per minute meter square. So, sorry. When it comes to the energy balance, we also do see, and that's men contrasted towards women, that we do have a lower calorie intake and a higher energy expenditure in the groups treated with SGLT2 inhibitor. So what is driving the glucosuria? Of course, it is mostly defined by the glycemia. So glycemia will bring down or will increase the rate of glucose that you can excrete via the kidneys. But of course, it's also depending on the kidney function, because if kidney function is not good enough, SGLT2 inhibitor do not work as good as they do in people with normal kidney function. So when should we use SGLT2 inhibitors? So we should, of course, start using them already quite early in the treatment, because there they have the highest glucose lowering efficacy. And if we go down the line, they lose, of course, their efficacy, but are at least not unsafe in a kidney, in a population with kidney disease. And then we had the first positive cardiovascular outcome trial that was presented at EASD, and people were really cheering and giving standing ovations to empagliflozin, because it was the first SGLT2 inhibitor that showed a positive cardiovascular composite outcome with a hazard ratio of 0.86 compared to placebo over treatment of 4 years. Second in line was then the study looking into canagliflozin, and they looked not only into cardiovascular death, but already started to look in end-stage kidney disease, doubling of creatinine, or kidney and cardiovascular death. And again, we saw the benefit of canagliflozin compared to placebo. And then EMPA-KIDNEY again looked into kidney disease progression in seeing if there was a difference in requirement of dialysis, kidney transplant, in eGFR below 10 milliliters per minute, a decline of kidney function above 40%, or kidney-associated death. And that included people with and without diabetes, and people with and without albuminuria. And what was observed, again, there was a big difference between placebo and empagliflozin, favoring empagliflozin as well in that population. So when should we use SGLT2 inhibitors? also in the people with declining kidney function, also in those people where normally we need to recommend potentially still to stop metformin. There might be a little bit less efficacy, but at least they are safe and might give us some cardiovascular and kidney benefits. Then comes looking into the heart failure and ejection fraction. And here dapagliflozin was the first to prove that also a composite endpoint could show a reduction in a composite endpoint of heart failure and hospitalization for heart failure in a course of 2 years' time. The DECLARE study, again, with dapagliflozin, looked into people with already established cardiovascular disease or prior heart failure. And also here, we could see that there was a reduction in hospitalization for heart failure and hospitalization in the group with heart failure history, and a reduction in hospitalization for heart failure in the people who had a cardiovascular disease history. So again, when should we use SGLT2 inhibitors? So we should use them in people with normal kidney function, in people where we see a slowly declining kidney function, and as well in people where we need to have more cardiovascular protection. And importantly, really, we need to understand again that we do have clinical inertia all around, that especially in those, maybe if they even do not have cardiovascular disease, we do not sufficiently improve our diabetes management and help our people with diabetes to achieve their treatment goals. And I promised you to show you also data from Austria, from our national registry, that we asked also primary care physicians to provide, and it was a countrywide cross-sectional study. It was published last year. And so here you can see the distribution of medication that is established in routine care, in primary care in Austria. So we do see that the majority of people are on metformin. Also quite a big group is already on SGLT2 inhibitors, followed by DPP4 inhibitors. Group of GLP-1 receptor agonists is smaller, probably also due to the properties of needing to be injected, and insulin ranges still quite low. When we look into the blood pressure medication and lipid-lowering medication, we do see that at least 70% have any lipid-lowering medication, and also blood pressure medication is established in roughly 1/3 of the people. But, and now come the frustrating results, we do not achieve our treatment goals. So when we look into LDL treatment goals, only short above 40% of our people achieve the goals. HbA1c, only 50% plus achieve treatment goals. Same for blood pressure. And if we then look into the composite of all of the three of them, we only see that only roughly 10-15% of our people achieve these treatment goals. So it's really in our hands to overcome our inertia in really improving our diabetes care. And potentially one of the solutions is not only having single medications, but really using fixed dose combination products, because they probably will help to improve adherence on the one hand side, and could also help to reduce costs for the individual. I'm really not that familiar with your reimbursement scheme in India. I know that there are some reimbursements available, but that a lot of monies or a lot of medication is paid out of pocket. So in my country, for example, when I get one medication, we need to pay one fee for one prescription. But if it's a combined medication, it would be the same fee. So I could imagine that the rate of people preferring combined medications is quite high compared to those who need to go with single prescriptions and pay the double amount to receive then the same medication. And when we look into the study done in Korea, so that's a study looking into linagliptin plus dapagliflozin compared to linagliptin plus placebo. people were well matched in those, roughly 120 participants per group when it comes to HbA1c, also age distribution, kidney function, and fasting plasma glucose. And what was observed over time, so that already at week 12, there was a tremendously bigger HbA1c reduction that was sustained over the treatment phase, and the proportion of achieving HbA1c targets below 7% was statistically significant higher, and also people who achieved HbA1c target of below 6.5% was significantly higher in the group treated with the fixed dose combination of linagliptin and dapagliflozin. What adverse events were observed? In general, there were only small numbers of adverse events if you consider the long duration of the study and the high number of people, and medication events that led to discontinuation were only observed in 2 and 1 cases in the groups. And here comes now a study performed back in your country in India, where people who were on a stable dose of metformin for 6 weeks were then randomized to receive either dipeptidyl peptidase inhibitor with or without metformin, and were then treated for a period of 16 weeks. Primary endpoint was change in HbA1c at week 16. Secondary endpoints included achieving the HbA1c target, changes in body weight, fasting plasma glucose, and also safety data. So what was the population? Not well controlled at study start, fasting plasma glucose also high at study start, and also body weight was comparable, let's say, between the groups. So it was 262 patients for 16 weeks. What was observed? An HbA1c reduction of 1.35% was observed. Fasting plasma glucose and also postprandial plasma glucose were reduced. And if you remember, we discussed 1% HbA1c reduction is associated with an improvement in cardiovascular outcome. 49% of the participants achieved an HbA1c below 7% in the group with dapagliflozin and linagliptin, compared to 26% in the linagliptin alone group. So what could we see? There was one hypoglycemia event. There were no deaths or hospitalizations in none of the treatment groups, and the treatment was well tolerated and safe by the people who were otherwise not well controlled on metformin monotherapy. Then there was a survey, and I found that one also quite interesting, where Indian clinicians were surveyed based on their utilization of combination therapy for the management of obesity in people with type 2 diabetes. And mostly diabetologists, cardiologists, and consultant physicians responded here. And the part that I looked at was how do they or why do they choose fixed combination drugs? And the answer was efficacy in glycemic control, weight reduction, followed by renal protective benefits. But of course, colleagues from Sweden also looked into the effectiveness of fixed dose versus loose dose combination in a nationwide comparative effectiveness study. And they could see, especially for heart failure and unstable angina, there was a benefit for the fixed dose combination. And these authors assumed that it was mostly due to the easiness of using the fixed combination rather than using the open or loose dose combination. But of course, and I promised you to also shortly look into the MASLD, because we do have more organs that can be affected in diabetes. So those organs of new interest are now also is now also the liver, because we do see that MASLD is quite common condition in people living with type 2 diabetes. And so the new term means metabolic dysfunction associated steatotic liver disease. We see that there is more lipid accumulation. There is an increase in ROS in the hepatocytes. We do see that there are more ceramides in the hepatocytes. There is an increased inflammation that can lead to fibrosis, subsequently can even lead to liver cancer. And of course, all of these conditions are not very favorable in the situation of type 2 diabetes. So we do have hypertriglyceridemia, which results again in more fat accumulation in the tissues. We do see increased insulin resistance. We do see increased inflammation also in the subcutaneous adipose tissue, and that in total contributes to our unhealthy situation in MASLD. So what can we manage by achieving weight loss by either medication or also bariatric surgery? We see that steatosis goes down. That is true both for GLP-1 receptor agonists and SGLT2 inhibitors. We see that there is a reduction in inflammation, a reduction in fibrosis, and potentially a reduced liver cancer risk. With the weight loss, especially if it is above 10%, we see that the endogenous glucose production goes down, which is then, of course, also positive for glucose control on the long run. So what are the interventions that are available? Lifestyle interventions, bariatric surgery, and weight loss medications. And very importantly, we do see also with approved weight loss medication, including GLP-1 receptor agonists and SGLT2 inhibitor medication, an improvement in the histological design of the liver, a reduction of liver lipid content, and of course, weight loss. And compared to bariatric surgery, which is of course always winning big time if you look into clinical parameters, at least the long-term tolerability of both lifestyle and approved medication is quite beneficial over the use of bariatric surgery, because it's an irreversible process. And I also found very recent articles on MASLD, where they looked into the effects of SGLT2 inhibitors compared to non-SGLT2 inhibitor use. Groups were quite comparable in their composition when it comes to body mass index, diabetes, hypertension, and liver-specific parameters. And what they saw over time, that there was a positive effect of the SGLT2 inhibitor, namely when it comes to survival probability, all-cause mortality was in favor in the SGLT2 inhibitor group. Also liver-specific parameters improved, and there was a lower risk of hepatocellular carcinoma. And then if you again look at 1 year, 5 years, and 10 years of follow-up, so that was quite a long follow-up group, you again could see that in the group that are exposed compared to those that are unexposed, there's always a favorable effect in those who have received SGLT2 inhibitors. The SGLT2 inhibitor group is always the darker group compared to the lighter group who is unexposed. So if we now come back to my slides in the beginning, potentially we need to revise our assumption and say that in the future we can also say SGLT2 inhibitors do have a positive effect on MASLD. So again, we need to bring everything together, and I just want to conclude, we need to see what are our goals of care, what are the underlying conditions, then make wise selections for the medication and really be motivating so that the people stay on the drugs and make life easier by prescribing the medication that is easily accessible and easily to adhere to. So that could be, for example, fixed dose combinations. Thank you very much.
Thank you very much, ma'am. It was an amazing session. So I think the Q&A part is open for now, and we are actually uh, having a lot of bunch of questions to be addressed, and it has been a very interesting session. So I would like to ask one question, which is how do you approach individualizing HbA1c targets in patients with varied comorbidity profiles?
Maybe Dr. Uni, you start and I jump in after.
Of course. I think most people with type 2 diabetes do have other comorbidities. If you look at obesity, dyslipidemia, hypertension, cardiovascular disease, metabolic dysfunction associated steatotic liver disease, so on and so forth. So I think it's important to choose a medication which can probably sort of be used in a scenario where a particular complication is most likely. For example, if there is microalbuminuria, you would like to use a particular medication, maybe SGLT2. If there's hyperglycemia, which SGLT2 alone may not be enough, you would like to add a DPP4 plus SGLT2. If there is a fatty liver disease or MASLD, then of course your choice would be some other agent. So similarly, we should sort of prioritize treatment based on what is the most likely complication. Of course, a higher variety of that would be called precision diabetes care. But I think we do this all the time in our practice. In India, another important aspect is affordability.
Exactly, sir. So I was coming to the same point that from your perspective, what is the biggest challenge in Indian context you are facing as far as managing diabetes is concerned, and how do you address this challenge, and what strategies you have found to be most effective in overcoming them?
Well, so I think that in India, fortunately, I'm in an urban hospital, tertiary care, so cost is not that much of a problem. Still, most people are looking for, appropriate price for a product. And once the SGLT2 inhibitors came off patent and the linagliptin and the gliptins also came off patent, there was a surge in the combination therapies, and one among them is the linagliptin dapagliflozin combination, which actually helps in good glucose control because of the combined effect of both drugs and the cardiovascular and renal protection of SGLT2 when added to it. That makes it a very compelling choice. And of course, metformin, of course, can be given together or separately, but I think this combination of DPP4, SGLT2 plus or minus metformin, very popular in India. And Indians, as was mentioned, are very Indian doctors love a fixed drug combination because it brings down the cost, improves bringing down the cost and bringing down the pill burden, improves adherence and compliance.
Right, sir. Totally agreed. So, sir, as far as the CGM monitoring is concerned, how that decision is taken to implement CGM, and what are the potential benefits and challenges with its use?
I think Dr. Julia is the best person to talk about CGM because of her immense experience in diabetes-related technology. And maybe Dr. Julia, over to you.
Yeah, so I think also in people without insulin treatment, we do see benefits, but of course, costs can be relatively high. And then so far, always the discussion was that maybe the cheaper CGMs might not be as good as the more expensive ones. But of recent, we have heard from a very well-renowned manufacturer that there were 7 deaths even reported due to underreading of glucose. So I think manufacturing problems and quality issues can happen everywhere. So we need to be very vigilant and diligent in our selection of the system, also who we recommend it to. It could be used as a motivational tool, maybe not continuously, but maybe for 2 weeks every half a year, and then repeatedly again every half year to see how glucose control improves. So I think for those who are not on insulin, that could be a viable approach. But I think we also need to be aware that a lot of people might just simply buy themselves over-the-counter CGMs and then approach people who have had no experience with CGM so far. And that's why we also brought a group of experts together in the last half year to write a consensus on how we should kind of classify the users of the CGM, not the people with diabetes, but us as healthcare professionals. So at least the surgeon should be aware that such a device exists and not remove it just because the patient comes into the clinic. But yeah, so it's going to be a challenging phase with more people being equipped with CGM. How to wisely use it, that will be the challenge of the next 5 years or so, I guess.
Exactly,
I
ma'am.
completely agree. I think recently there was this IFCC working group which released a statement on CGM devices, and in India there are many CGMs now available. But I always urge the listeners to go for the best possible CGM, because as Dr. Julia mentioned, uh, if the patient banks on a CGM which is of low quality, and if it misses a severe hypoglycemia, then it can be life-threatening. So the other thing is there are many people without diabetes who are putting a CGM. Well, again, that's a long-term risk, but probably it's not so risky. But at the same time, I see little benefit in people without diabetes putting CGM and looking whether their cup of tea has increased the glucose from 140, sorry, from 102 to 104 or something like that. But I guess there are lots of startups in India which have received funding, and there's a lot of money in the system allowing them to sell CGMs at a cheaper cost to people without diabetes. As doctors, we should not just write CGM only in those patients who need it. And also, whenever we are on social media, we as doctors in India, we should pass on the message that CGM is a diagnostic tool to be used carefully, and it is particularly valuable in people with diabetes, and probably the use in people without diabetes just looking for some cognitive biofeedback may have its limitations and may have some cost concerns also. When the startup funding runs out, the medication, the CGM cost is going to go up, because right now it is sort of subsidized by money flowing from the angel investors into startup ecosystems.
Exactly, sir. Totally agreed. So, I think one of the aspect is regarding the adherence part. So, since there are multi-drug regimens, what strategies you find most effective for improving adherence in, especially in the rural settings, as far as India is concerned?
Well, in rural settings, a drug which brings the blood glucose levels down without hypoglycemia is the best drug. Because when we did the rural diabetes project, I had an opportunity to go to the villages and see the situation. And I particularly remember one particular medical shop in a village. And this was more than 10 years ago, so it's a long time ago. But for 6 villages had one medical shop. And I asked that medical shop, because he was stocking medicines on all diseases. So I asked him what medicines for diabetes he has. So he said he has mixed-tard insulin, and he also has a combination of glibenclamide, which is glyburide or glibenclamide, and pioglitazone and metformin. So he also had some glimepiride, metformin, pioglitazone combinations also. So I think it's time that we look at access of drugs like dapagliflozin or gliptins and metformin, especially the combinations to be available in rural India, because now the cost has really come down, and making it accessible uh, by good companies which manufacture good products, I think will help people in rural India to a great extent, because rural India is not that very poor anymore. Many of them are wealthy, they just don't have access. So I think that needs to be taken into consideration, and such medications, combination therapies, which bring down blood glucose without hypoglycemia are safest. And if, like, say, an SGLT2, they provide a cardiovascular, renal, heart failure advantage, that's an added bonus.
Exactly, sir. So since you have mentioned the dapagliflozin gliptin combination, I would just want to inquire about how do you approach the selection of patients which are ideal for this combination?
Is a question to me or to Dr. Julia?
It's a common question. Both anyone can take it up.
Dr. Julia, ma'am, please go ahead.
Yeah, maybe I start and then you take the Indian perspective. So usually what I personally would do in our clinic, and there we have a bit mixed feelings across our team, of course, as you never are fully aligned with everyone. So I personally try to hit hard and early. So if HbA1c is quite high, I would not start metformin, start the next medication and the next medication, and always wait for 3 months until I intensify the therapy, but really try to start at least with a dual combination, maybe add a triple combination if available, and reassess in 3 months. And then if the treatment goals are not met, then intensify, because the problem is our waiting time is quite long. So usually, even if we try to give people a follow-up appointment on time, it's not 3 months, but it's 4 months, then it's not 6 months, but it's 8 months in total. And that really delays the achievement of the glucose control. And secondly, also the people then believe if they do not like meet the treatment goals, and if we are quite sloppy in our start, maybe glucose is not that important. So I think that's also their glycemic legacy in their mindset. And of course, if people are truly overweight, I would also consider adding GLP-1 receptor agonist quite early. But out of reimbursement, I need to start at least metformin and SGLT2 inhibitor before I can move on in that direction.
I was also just thinking about what are the situations where I prescribe a linagliptin dapagliflozin combination. So one common situation in India is metformin intolerance and the HbA1c being, say, 8%, and that in that situation a linagliptin dapagliflozin would be a good combination choice. The second situation is if blood glucose is uncontrolled on a metformin plus DPP4, or metformin alone, or a metformin plus a gliptin, then adding a lina-dapa to that metformin background would be a pretty good choice. The third situation is when a patient is coming taking a linagliptin 5 mg and a dapagliflozin 10 mg separately, it makes sense to combine it into a single prescription to ease the pill burden. The fourth situation is when the patient is on, say, insulin and is also taking all these drugs, or patient is on multiple oral drugs and you've got to throw away a few because you're going to start insulin. At that point, it may be a good choice to just combine, use combination pills, because you're anyway going to add insulin. And when patients who are started on insulin always ask, doctor, will I have to take all these medicines? And you can always tell them, no, I'll try to reduce the number of pills and I'll give you insulin. So that becomes a good negotiation tactic to get the patient onto insulin, that yes, I'm going to cut down the number of pills. So I think these are all situations where we have managed to use fixed drug combinations so that we can improve adherence and improve patient satisfaction.
And maybe an interesting treatment case or cases that I've started that type of treatment recently were the ones who received immune checkpoint inhibitor treatment for melanoma, for example, and developed the diabetes. And in the early stages, at least, they still produce insulin. Sometimes it really decays quite fast. But in those who do not go down that fast, I really like the combination of DPP4 inhibitor and SGLT2 inhibitor because it brings glucose down quite nicely. And I even keep it if I need to introduce the insulin because it caps away the postprandial peaks.
Thank you for sharing that.
Yes, agreed, ma'am. So, of late, there has been a big debate over MASLD patients. So, as far as managing such patients is concerned, ma'am, which pathway you feel is the dominant pathway, whether via weight loss or via insulin sensitivity or via the reduction in the visceral fat?
I personally think it's a combination of the three, probably driven mostly also by the weight loss, and that helps us to get glucose down. And I think we overlooked so many MASLD cases so far because we've seen AST, ALT, GOT, GPT elevated. And we said, yeah, it's an NASH at that point in time. And no one really looked further. We did not send them to ultrasound. We didn't do the ultrasound ourselves. So I think that's really going to be the brand new area of research. And I'm really looking for the next year to see what else we're going to see. And maybe also outside or out of your community in India, you have so big data sets available. So maybe that could be something interesting to look at what's the prevalence at present and then see how those combinations affect the outcome.
So, ma'am, when it comes to considering SGLT2 inhibitors in MASLD patients, do you feel that SGLT2 inhibitors demonstrate consistent benefit in both early stage steatosis and established fibrosis?
So I personally think we do not have enough data yet to really say that. So what we see are mostly from observational data. It's not really that clinical trials proactively looked into it. So I think the next trial with an SGLT2 inhibitor on a longer term basis, really specifically looking into liver parameters, is really highly needed to look at it. But what we have seen in clinic in those cases, that really steatosis goes down. Fibrosis, actually, I have to admit, I, knock on wood, do not have that many patients. I have to really say that most of them are still in steatosis phase and not too many are in fibrosis phase. And also liver cancer out of MASLD is not that common in Europe. I don't know if there are other triggers that drive it even more, but like in our clinic, those are really rare cases. It's more driven by alcohol consumption rather than by the glucose alone.
Right, ma'am, totally agreed. So, sir, who is the right MASLD patient for dapagliflozin use? So, how do you see that?
So if you look at type 2 diabetes and MASLD, currently the only approved drug by the US FDA is injection semaglutide, which is now approved for F2, F3 non-cirrhotic MASH. But in India, I think right now injection semaglutide is expensive. Of course, it is going to become cheaper later. Resmetirom, which is also approved and available in India for compassionate use very selectively. So that leaves us with what are the choices that we have? Pioglitazone, there's a study, RCT in Hepatology 2004, but I don't prescribe pioglitazone and not certainly at 45 milligrams because of the side effects and the toxicity profile. Now that leaves us with mainly other GLP-1s and which are on their way out. If you look at liraglutide and other dulaglutide and not going to be available. Tirzepatide, the Synergy NASH trial is itself not powered for MASLD. And that brings us to which are the other drugs which have got RCTs in MASLD or MASH. There is an Indian RCT published in Diabetes Care on empagliflozin, and of course, there is a Dean study which was published on dapagliflozin RCT, both showing benefit. So SGLT2s, by having some impact by carbohydrate restriction mimicry on reducing de novo lipogenesis and liver fat. So good choice. And the second choice is linagliptin, which of course, despite changes in liver function, it does not require dose readjustment. So both of these make it a fascinating choice for adding on to people with type 2 diabetes and mast cell. But like Dr. Julia mentioned, the natural history itself of mast cell and MASH in Indians is not well known. We don't know how many people with mast cell are going to progress to MASH, are going to progress to cirrhosis, to liver failure, to hepatocellular carcinoma. Right now, we don't know the outcome. So, like I said, the best choice probably is in the absence of availability of injection semaglutide, which is also expensive and has lots of side effects, GI intolerance. I think linagliptin, dapagliflozin is a compelling choice here. One of the compelling choices in type 2 diabetes and mast cells.
And
Right, sir.
because you mentioned the dose adjustment, I think one of the reasons also why my colleagues GP really like linagliptin is because even if people have kidney function problems, they don't need to think about that medication anymore. So that's really easy to prescribe, easy to maintain medication, and that's why people really favor that kind of drug next to the
Yes.
tolerability.
So, ma'am, there is one more query which is very common, that is there a synergistic benefit in combining dapagliflozin with statins for cardiometabolic protection in the MASLD category?
Say again, is there a cardiovascular
Is
benefit?
there a synergistic benefit of DAPA plus statin for cardiovascular protection in the MASLD patients?
Of course. I mean, the majority of MASLD patients will also have increased lipids, LDL out of the goal, potentially being already or having already had a cardiovascular event. So that would for sure be beneficial to add both SGLT2 inhibitor and the statin. Interestingly, and we do not observe LP minus A that often on the follow-up, but I was just in a lecture here in Mexico where they discussed that potentially some people might see an increase in their LPA after the statin start, and that they are now considering to revising the guidelines in those individuals. So it would be really maybe smart also in our clinic to follow on the LPA, because especially in those who are already at a higher risk, so in the higher level of LP small a when we start the therapy. So here maybe our treatment algorithms could be adjusted. Currently, it's a one-time measurement in Austria for the people who are seen by experts, but usually we do not do follow-up measurements. But then to see in that high-risk population, especially if we start a statin, if LPA increases, and if we should switch to another drug, that's quite an interesting research question as well.
Right, ma'am. So, as far as the future of DAPA and linagliptin combination is concerned, how do you see the combinations used in the MASLD patients?
Sorry, that was breaking again, so it's a bit.
Uh, how do you see the future as far as use of DAPA-LINA combination is concerned in the MASLD patients?
So I think that will be one additional group that will benefit and potentially get their own box in our treatment algorithms, where we specifically recommend medications because of their liver-associated benefits. And for sure, we have seen that already for the DAPA. For Lina, I think it's currently neutral, but at least it doesn't do any harm, which is also good, and it doesn't do any other harm, which is also good. So we were discussing the cardiovascular complexity of pioglitazone, and maybe also the bone issues that we have observed with glitazones. And so I think that's a very stable and well-tolerated therapy that can be used in that patient group.
Totally agreed, ma'am. Sir, I would also like to know your perspective on the same. How do you see the FDC's use in MASLD patient?
I think it's already being used in India in type 2 diabetes with MASLD. Many patients are already on dapagliflozin and linagliptin. And I think the reasons are, like Dr. Julia mentioned, the ease of administration. You don't have to change the dose in hepatic or renal disease. And the dapagliflozin comes with obvious benefits on reducing mast cell and, of course, on cardiac and renal comorbidity. So I think there is a strong case to use it in type 2 diabetes with mast cell slash MASH.
Exactly, sir. I totally agree. So, I think with this, we are coming to the end of the session. So, I would like to request Dr. Julia to recapitulate and give the final statement over how she thinks over management of diabetes in the future.
So I think, and thanks for the opportunity of speaking here. And I really enjoyed the discussions and the very lively discussion also via your online chat with the audience. So I think we are really now at a fork in our treatment where we already have more knowledge than maybe in the last 1 to 5 years about MASLD, how we should treat it. We see more fixed combination drugs coming out, which leads to a higher adherence by the people with diabetes, and that, of course, facilitates achieving our treatment goals, and that helps us to avoid complications. So I think the future will really be in fixed dose combinations and hitting hard and hitting early to really avoid those complications on the long run.
Exactly, ma'am. So, I would also request Dr. Unni sir to recapitulate how he thinks.
Well, since you have asked me to recapitulate, I was just remembering my childhood when there were only 2 cars or 3 cars in India. We used to have an ambassador car, and then there was a Fiat car, and then there was a car called Premier Padmini. So these were the only 3 4-wheelers available in India at that time. Today in India, we have Maruti, we have Toyota, Fiat, Renault, Kia, Ford. I mean, we have so many vehicles. Similarly, in diabetes, earlier we had only a few medicines. We had sulfonylurea, metformin. Now we have so many medicines. In addition to sulfonylurea, metformin, you have SGLT2, DPP4, alpha glucosidase inhibitor. You have different types of insulin, oral GLP-1, injectable GLP-1, uh, injectable insulin GLP-1 hybrids, so on and so forth. So I think this choice has really helped us to help the patient. Ultimately, it is between you and the patient sitting in front of you. We have to decide which medicine to give it. And in India, we have to go by affordability, accessibility, tolerability, side effects, ease of administration, and dose adjustment. So metformin, linagliptin, dapagliflozin, and particularly the linagliptin-dapagliflozin combination is likely to find an important niche and have a good role in the management of type 2 diabetes. As you mentioned, with cardiorenal protection and MASLD benefits put in together. So individualize your care and focus on the patient and discuss with the patient and go ahead.
Yeah, thank you. Thank you so much, sir. So I think it has been an amazing session wherein the evidence of diabetes management was beautifully shared, and it has been highly valuable and insightful for us too. So all thanks to Professor Julia for taking us through the deep dive in a highly engaging manner and such insightful slides. And many thanks to Dr. Oni sir for taking us through the Indian context too. And so it's been a great opportunity in presence of you both, where we could gather and generate significant insights, which would also help us in future and may benefit thousands of patients in the community we serve. as Sir showed us beautiful pictures of Chelaram Institute and the older ones where he was young also. So the community that he served is a massive community, and we would like to gather more significant insights to help that community. On behalf of Sun Pharma, once again, I would like to thank our esteemed speakers, Dr. Julia Madra and Dr. Onisa. Also, I would like to thank our sales and marketing team for their consistent efforts in making this wonderful session possible. So, I think with this, I would like your permission to close the session, sir. And ma'am.
Thank you.
Thank you so much. Have a good evening.
Thank you and good evening.
Thank you so much. Good evening.
Thank you, sir. Thank you very much.
Thank you.
Yeah.
Thank you. Do you actually have